Welcome back. Assessment and diagnosis today. We'll start off with the mental status exam. So what are we talking about with clinical assessment? Measuring in at least 3 dimensions the issue in front of us and the individual bringing that issue to us. Most assessment is rather obsessed with diagnosis, which is fine if you take the traditional meaning of diagnosis, which is profound understanding. But if you take it to just mean labeling someone or labeling their problem, then you could easily make a case that focusing on diagnosis might distract you from what the client actually needs. Connection, insight, understanding, working through, reflection, comfort, recontextualization. In other words, there's lots of good reasons to criticize the rather monomaniacal focus on diagnosis in clinical assessment. Just keep in mind that people mean different things when they say diagnosis. I have evolved since my undergraduate days to be more charitable towards use of the term, and I tend to assume now that when people say diagnosis, they just mean an understanding of the case in front of them, an understanding facilitated by the appropriate labels. Because, as any English professor will tell you, if you can't find the right words, then you don't understand what's in front of you. So let's start with the first meeting, and your first task in the first meeting, which is to conduct a mental status exam. 5 sections. You haven't actually been assigned this chapter, but if you did, this would be part of it. In your first meeting with a client, you will be assessing for the sake of your records and in order to have the most objective perspective of the individual and their interaction with you as possible, their appearance and behavior, their apparent thought processes, their mood and affect, mood being how they describe themselves and affect being their apparent observable emotional responses, their intellectual functioning, and what we fancily call sensorium, i.e. whether they know where they are and have some basic self-perception and awareness. Now, depending on your goals and depending on your discipline, you will have different versions or forms or breakdowns of the mental status exam. So the Barlow textbook gives you this breakdown and says this is what psychologists in Canada do. These are the categories and the checkboxes that they go through. But I have to show you at least one slightly different version in part so that you know what to expect when you actually get into the real world, and whatever company or place or discipline you're working for has a different version of the mental status exam. This is so that you're not surprised. This is a more clinical/medical mental status exam from this psychiatric interviewing textbook I have, and I actually prefer its approach because it splits up thought processes into different subcategories. So first it has appearance and behavior, but then it splits thought processes up into 3 categories. So you have your speech characteristics and thought processes. Then you have thought content. This is where we could explicitly and individually evaluate things like delusions. And then you have perception, where we can individually and singly evaluate things like hallucinations. Then you have mood and affect. And whereas Barlow's abnormal psychology text has intellectual functioning and sensorium as separate categories, the psychiatric interviewing text puts them in the same box as sensorium, cognitive functioning, and insight. And of course, if we were doing a neurological type of mental status exam, we would likely split this category up even further into various subtypes of intellectual functioning, and likely various tests to evaluate sensorium and things like delirium as well. So the actual structure and content of the mental status exam varies from place to place, but these 5 categories do seem to cover pretty much everything. I just like how the psychiatric approach better splits up the thought content. So before we go any farther, the mental status exam exists to help us record as faithfully and accurately as possible the individual when we first meet them. Memory is malleable, and we are liable to make errors of recall that fit with whatever is currently in our minds. So recording the individual's state and appearance as objectively, as faithfully as possible is vital to avoiding all kinds of bias, including false memories, later on. These observations are not necessarily geared toward diagnosis. Sure, that's the overarching goal in general, but we're not making every observation with the idea that it is going to be pertinent to some sort of diagnosis. One of the items on many of the checklists that try to make the mental status exam process easier for clinicians is whether the person had a cane or not, so whether they used some assistive walking device. Now, we don't know whether or how the fact that someone used a cane in their intake interview could be useful to us. but having it recorded as something that occurred could be useful in case that variable changes somehow. And we can trust the observation much more if it's in our actual notes rather than just we think we recall that they had a cane at the first meeting, but they don't now. So the mental status exam gets us to look carefully at what's in front of us, gets us to record what's in front of us so that we don't screw it up with our memory later. And not everything we write down is intended to be relevant or is expected to be relevant to later analyses or diagnoses. The best way to break down the mental status exam is to use one of the scaffolding checklists that some individuals use for their mental status exam procedure. In order to evaluate appearance and behavior, some people go through and they actually check off or circle from the following lists what is relevant or what is present. So here are some checklist examples for assessing appearance and behavior. Psychomotor activity. Is the individual engaging in a normal amount of psychomotor activity? So, maybe, once in a while, shifting in your seat or tapping your foot once in a while. Or is it overactive? So are they constantly moving, hyperkinetic, or underactive? Are they just still as a statue? We don't know whether this is going to be relevant to anything later on. If they're overactive, well, maybe they're going to be found to have hypomania later on. Maybe. The checklist just gets us to look and to record so that our memory later on will not be fooled into putting something there that fits that wasn't actually there to begin with. Next, apparent age. Does the person seem as old as they chronologically are, or do they present as younger or older than they actually are? Is the person overweight or obese or underweight? How is their grooming? Are they appropriately dressed for the meeting, or is it inappropriate? Inappropriate might be sweatpants, inappropriate might be a tuxedo. Is their dress a little off? There's a section for makeup, a reminder to look at people's exposed skin, and to look for any scars, and a place for any medical observations. Your checklist might look different. You might think that the idea of having a checklist for this type of task would get in the way of you using your own eyes and insight, but clinicians do, on occasion, use these checklists to remind them to be thorough and to explicitly state what is not there, because we're very biased towards what is there, and what a checklist will do is we'll say, no, there wasn't any abnormal psychomotor activity. In other words, the checklist reminds us to notice what's absent, something our brain often needs to be reminded to notice. This is also where we would notice whether someone used a cane or not. So these are some checklist examples for appearance and behavior, what you might see in an actual clinical description once an individual clinician has made their observations, maybe with the scaffolding of a checklist, maybe not, would be something like this. The patient presents in tattered clothes, all of which appear filthy. Her nails are laden with dirt, and she literally has her soiled wig on backwards. She's wearing 2 wristwatches on her left wrist and tightly grasps a 3rd watch in her right hand, which she will not open to shake hands. Her arms and knees moved restlessly throughout the interview, and she stood up to pace on a few occasions. She did not give any evidence of active response to hallucinations. She smelled badly, but did not smell of alcohol. At times, she seemed mildly uncooperative. So there's our clinical description pertinent to appearance and behavior. Now we can move on to thought processes. The checklist approach has us look at things like the fluency of language, the client's ability to understand the language that we use, various features of how the client constructs their speech, the presence of speech errors called paraphasias. So did the client use a word that kind of sounds like the word that they meant to say? So I'll tell you what I did on the deep end rather than I'll tell you what I did on the weak end. Or do they make syntactical types of paraphasias? So hearing and talking are in the same conceptual family. Do they say, I can talk you just fine? A paraphasia that might fall in both camps might be, I can clear you. So that's in the conceptual family of hear, but it's also an auditory paraphasia, because hear sounds like clear. This is also where we evaluate thought content, so what is it that the client is talking about? In the psychiatric interview, this is parceled out as thought content in its own category, and here we're looking for red flags regarding the client's potential risk to themselves or to others. And we're assessing whether they seem plugged into reality or maybe verging on delusional regarding their beliefs about themselves or others. There's a whole lot packed into the thought processes subsection of the mental status exam, especially for the psychologist and psychiatrist. So those were just a few checklist items. The psychiatric interview approach looks in more detail and will look at rate of speech, whether speech is pressured, meaning there are very few gaps between sentences or between topics. We're also looking for tangential thought, the key feature of which being if you have one sentence and it makes you think of something else, and that makes you think of something else, and that makes you think of something else, and you never return back to your original idea or your original topic, then that is tangential thought. If you do go on a circuitous route, but you actually end up back where you started, so you kind of make sense of your tangent, then that's called circumstantial thought. We're also looking for loose associations, or what's also called word salad. And like the Freudians before us, we're still looking for what tends to be called thought blocking. If a client stops talking, well, maybe what they had been talking about has deep unconscious significance, or maybe they were interrupted by a hallucination. Either way, their thoughts being blocked or interrupted could have clinical meaning or significance. We're also looking for ruminations, obsessions, compulsions, and whether the individual at any point seems to be responding to something that is not there. So there's a lot happening in the thought processes subsection of the mental status exam. What this might end up being written up as in a clinical description is the patient demonstrates a moderate pressure in her speech. Note that this means she's not pausing, as if what she's saying does not have punctuation. It's just words at the end of one sentence and the beginning of the other are ran through just the same as the words between or in the middle of sentences. Accompanied at times by loud outbursts. Even her baseline speech is slightly louder than normal. Her speech is moderately tangential, with rare instances of a mild loosening of associations. In other words, what she says in sentence 2 and sentence 3 appear to have very little to do with what she said in her first sentence. Continuing with the clinical description, without thought blocking or illogical thought. So she doesn't appear to stop mid-sentence and never return to her original ideas, and she doesn't appear to present any reasoning that is patently wrong where she demonstrates reasoning. So those are her speech characteristics and thought process. Moving on to thought content, the patient appears convinced that if the watch is removed from her right hand, the world will come to an end. So there's a clear delusion. She proceeds to relate that, consequently, she's not bathed for 3 weeks. She also feels that an army of rats is following her and is intending to enter her intestines to destroy, quote, my vital essence. She denies current suicidal ideation or plans. So why do we include that in the report? Well, firstly, to show that we inquired, and secondly, to remind ourselves of what was not present. She denies violent or homicidal ideation, also denies any thoughts of self-mutilation, without ruminations, obsessions, or compulsions. Okay, so that's thought content. Moving on to perception. The patient denied visual, auditory, and tactile hallucinations, and any other perceptual abnormality, such as illusions. But we write it down to remind ourselves that we asked and to show that we're doing our due diligence with regards to the mental status examination. Next, mood and affect. Recalling that mood is how the client reports themselves to feel, and affect is what we observe in terms of their actual emotional responses to things. Checklist examples. How do you feel? What is your current mood? Please describe it to me, and I will write it down faithfully. I will also be observing you. And if you say you are very happy, but your face says that you are worried or scared or anxious or angry, I will also be circling those words in front of me. I will be also assessing whether you seem to display the range of affect that is normal. I may observe restricted, blunted, or flat affect. In other words, not much movement. And then I might look at how much you move within this range, or how often. So if I note emotional lability, that means that your affect or feelings are changing very much over the course of the interview. Maybe certain topics very easily get you excited, but that excitement leads to other emotions. If you are emotionally all over the map, this is where I would note that. And if you say you're telling me a sad story, but you don't appear sad, or if you say you're telling me a funny story, but you don't appear amused, then this is where I would note that you appear to be demonstrating affective incongruity. And again, I don't necessarily know if any of these observations are going to lead to anything in terms of diagnosis or grist for future discussions. I just know I need to make sure to look for these things, their presence or their absence, so that I have the option of using it later in case it turns out to be useful. A clinical description for mood and affect. When asked about her mood, the patient angrily retorted, "My mood is just fine, thank you." Throughout much of the interview, she presented a guarded and mildly hostile affect, frequently clipping off her answers tersely. When talking about the nurse in the waiting area, she became particularly suspicious and seemed genuinely frightened, without tearfulness or lability of affect. Again, we note down what is absent. This is what the checklist gives us. It reminds us to make note of what is not there. Next, intellectual functioning. The most basic checklist approach here is just to generally bin someone in terms of the level of the language that they use. So do they speak more like a book, or more in slang or idioms, or is it some kind of blend or normal for the circumstance use of language? Normal usually meaning that they try to match your level of formality, and this is just for observation of the meeting. How did they speak in this initial meeting? They could be putting on more formal airs, or they could be someone with multiple PhDs who prefers to speak in slangy and idiomatic phrases. We're not circling what type of person they are, just how they spoke when we first met them. Most clinics will have a kind of short list of questions that we can ask individuals for a mental status exam. Similarity questions might be, in what way are a pen and a pencil alike? How are they the same? And an example of a good abstract or conceptual answer to that question would be, well, they're both, tools with which humans write. Okay, great. A more idiosyncratic response to that might be, either one of them could be used to stab you. And a simpler or more concrete answer to that question would be, well, a pen and a pencil aren't alike. They're not the same. A pencil is a pencil, and a pen has ink, and it's a pen. This question is not revealing their quality as a person or the nature of their soul or anything. You're just kind of getting some relevant information for how they address problems. And usually the shorthanded description we use when we're assessing intellectual functioning is we're seeing how prone to abstraction or conceptualization a person tends to be. We might ask the individuals things from their past that are maybe in their chart or their records, things that they should know. See whether they can answer these questions and whether they're comfortable trying to answer these questions. We could also do various delayed recall types of tasks. So I might say, listen to these 3 words: blue, book, sun. Can you repeat them back to me? Blue, book, sun. Yes. Okay. Now, anyway, moving on, and then I ask some other questions, and then I come back a couple of minutes later and I say, okay, what were the 3 words that I said that you said back to me? And we'd see whether the person can remember them. And for immediate recall, you could just do letter numbers. So I'm going to say some letters and numbers, and then I want you to say them back to me, saying the numbers first and then the letters. A12C. 12AC. Great, good work. Now, if we're serious about assessing intellectual functioning, we have tons of great IQ and developmental related tests that we could run to do a very good job of assessing the individual's ability to abstract, to recall, to translate, to manipulate, to complete, to order, to copy, etc. But in most cases, we're not going to take the hour to hour and a half that it takes to run an IQ test. We're probably just going to do 3 or 4 little immediate recall and delayed recall types of tests, and infer the rest from the language and concepts that the client tends to use. And the checklist would also probably have an option that would note that, for example, if we have somebody who seems to be very high functioning in terms of intelligence, we might note that they are status incongruent if, despite this apparent intelligence, they do not appear well put together or well dressed, or to be, by appearances, succeeding. The psychiatric interviewing approach combines intellectual functioning with sensorium and insight, so we'll move on to sensorium, which tends to be pretty simple. We ask, who are you? Do you know who I am? What is the time and date? And where are you right now? And if the client can answer all of 3 of these questions, they are said to be oriented times 3. If you're lucky enough to live to be very old, so that they need to start checking you for dementing, then you'll get very good at, in doctor's offices, answering the question, what is the date? So you may have no difficulty with orientation, or you may make some errors, and you may make what's called a normal error, or you may make what's called an abnormal error. So if I ask you, what is the time and date, and you're off by 1 or 2 days or 1 or 2 hours, well, then that's a normal error. It's not correct, but it's a normal error. If you tell me that it's 1997, well, that is an abnormal error. You've made a serious mistake. Same with place. Say you're at a clinic and you get the specific name of the clinic wrong. Well, that's a normal error. But if you say you're at the airport, then obviously that's an abnormal error. Next, can you get your own name and your own past or present occupation correct? Here I would just circle the one that you got incorrect in this checklist approach. And do you know why you're in the clinic? So for sensorium, cognitive functioning, and insight, here's your clinical description example. The patient appeared alert with a stable level of consciousness throughout the interview. Indeed, at times she seemed hyper-alert and overly aware of her environment. She was oriented to person, place, and time. She could repeat 6 digits forward and 4 backwards. So there's your immediate recall. She accurately recalled 3 objects after 5 minutes. Not bad. Other formal cognitive testing was not performed. Her insight was very poor, as was her judgment. She does not want help at this time and flatly refuses the use of any medication. So that last would be a reference to insight. So the mental status exam overall helps us organize our observations, which helps us to focus further attention, individualize what we're going to do to this unique client's needs, avoid what's called the what you see is all there is bias, i.e. make note of what is not there, and start a record for further study, rather than just relying on our rather malleable and suggestible memories. Next, standards for assessment. First off, reliability. We can kind of nail reliability, at least for some disorders. In most cases, the type of reliability we're after in psychology and psychiatry is inter-rater reliability. In other words, if a bunch of different psychologists and psychiatrists look at the same case, will they come to the same diagnosis? If yes, then we have good inter-rater reliability. We lack this for things like major depression and anxiety, but we do have good inter-rater reliability for things like autism and schizophrenia. But of course, you can have good reliability without having a necessarily useful or good tool. An example I like to give is I'll hold up a pencil and then I'll say, this is my test as to whether I am the Queen of England. If I let go of this pencil and it falls downwards rather than upwards, then I am the Queen of England. And then I drop the pencil and it falls down. And I say, so I guess I'm the Queen of England. But wait, I can see you're not convinced yet. I'll show you that my test is reliable. I'll run it again. And then I drop the pencil again, once again confirming that I'm the Queen of England. I have a very reliable test. No matter who holds the pencil and drops it, the pencil says by falling that I am the Queen of England. I have a very reliable test. It doesn't mean it has anything to do with the actual question that I'm using it to answer, which is whether or not I am the Queen of England. In other words, I have a reliable test. It consistently gives me the same result, and it would if other people dropped the pencil as well. But I just don't have a valid test. In other words, it has nothing to do with the actual question I'm trying to answer. Having a valid test requires having a reliable test, but having a reliable test does not mean that you have validity. Validity needs reliability. Reliability doesn't need validity. Reliability on its own is no guarantee of anything except similarity. What we want is validity, correspondence with reality, whether our test is measuring something important or useful is going to be determined by what it can predict or influence. Sometimes validity is relatively easy to establish, so when they were making the Wechsler abbreviated scales of intelligence, which is just a shorter IQ test, the way to make sure it was doing a good job of measuring IQ was pretty simple. You give people the WASI and you give people the WAIS, the full Wechsler Adult Intelligence Scales. Other times, your choice of outcome measure in order to establish validity is more questionable or more fuzzy. So for predictive validity, I might predict that your performance in something will get worse over time, as with dementia, or that your experience of hallucinations or your delusions will also get worse over time, or that things that don't seem like hallucinations or delusions now what are called prodromal symptoms, will develop into full-blown delusions or hallucinations in the future. There's lots of demonstrated predictive validity with a diagnosis of schizophrenia, but for some other disorders, it can be difficult to predict anything other than the already present, already accounted for symptoms. So if I have a child with conduct disorder who has broken the law, broken rules, and ended up with this diagnosis, well, I'm going to predict that the child is going to continue to break the law and break the rules. The challenge is moving past predicting what they've already done again. With conduct disorder, I might predict that they're going to, in the future, meet criteria for antisocial personality disorder. What we're looking for is correct predictions that we can make that are useful, that actually help the individual to anticipate something or to prevent something, to find a fruitful or helpful way forward. The key word for validity is prediction. Even if it's just prediction of some other score or some other category or some other diagnosis, can we predict something from the information/diagnosis that we have? This would be our indication that we are on the right track with this diagnosis, with this category, with describing the world as we're describing it. We're not just dropping pencils and declaring ourselves the Queen of England. We're identifying something that has some sort of causal or predictive relationship with the real world that is useful or informative. So we need reliability and validity, and we also need some sort of standardization. If I have a tool or a concept, I need it to be specific enough and explicit enough that other people know what it means and how to use it. So if it's a test that gives me a test result, well then I need to clearly communicate how the test is administered and how a score is arrived at. If different people are applying the tool a different way, or the test a different way, or if they're applying it the same way but coming up with different numbers somehow, then you're not going to have the reliability that's required for validity. The standardization process builds potential for reliability and validity into the tool or concept. Since IQ tests are pretty much the best standardized tool that psychology has created, let's look at intellectual disability. What does it take to get a diagnosis of intellectual disability? Deficits in intellectual functions such as reasoning, problem solving, planning, abstract thinking, judgment, academic learning, and learning from experience confirmed by both clinical assessment and individualized standardized intelligence testing, and deficits in adaptive functioning that result in failure to meet developmental and sociocultural standards for personal independence and social responsibility. Without ongoing support, the adaptive deficits limit functioning in one or more activities of daily life, such as communication, social participation, and independent living across multiple environments, such as home, school, work, and community. And onset of intellectual and adaptive deficits starts or occurs during the developmental period, i.e., when the person is young. We'll talk more about this in the neurodevelopmental disorders lecture. What I would like to focus on here is this, confirmed by both clinical assessment and individualized standardized intelligence testing. In other words, you can't get a diagnosis of intellectual disability without taking some form of IQ test, some standardized intelligence test. It used to be the case that you only needed to take an IQ test to get an intellectual disability diagnosis. Now it is just a part of the diagnostic process. So the average IQ score is 100, and the cutoff for intellectual disability is roughly 65 to 75. We'll talk more about that later. We know IQ scores are reliable. If you take an IQ test in 2020 and then you take an IQ test in 2023, the scores will probably be within 5 points of each other. That said, you can raise your IQ. It just takes time, and it takes dealing with difficult types of problems that expand your ability to reason abstractly. If you had to place a bet, betting on your IQ not raising would be the smart money, as backward as that sounds. This probably does not need to be said, but IQ testing before the age of 3 yields unreliable results. Why would anyone think otherwise? Because in some places in New York City, there are posh daycares/preschools that have IQ cutoffs for the toddlers. In Poe Bronson's book Nurture Shock, she notes that less than a quarter of the kids who meet the high cutoff of the IQ test at age of 2 actually stay in that high cutoff bracket upon later retesting. In other words, the cutoff tests that they use are so unreliable that 3/4 of the kids who had IQs at age 2 high enough to get into the club no longer have at ages 3, 4, 5, and 6 the IQ that would presumably be required to stay in the club. Your IQ score gets more and more stable as you age, And by the time you're in your 20s, you can't expect too much of an IQ change, especially after age of 25. But the brain is very plastic, so you could just put that another way and say, well, it just takes a little more work to get those extra IQ points. And by the time you're at the age where that extra work is required, you probably have the wisdom to not go chasing after some abstract IQ score. You're probably at that point trying to apply the gray matter you have more judiciously. So IQ scores are highly reliable, in part because we've done such a good job standardizing the assessment of IQ scores. They're a great example of a valid test because they seem to correlate with pretty much everything. And this isn't necessarily because IQ causes other things. It's often because IQ captures something else, like cultural literacy, nutrition, social class, conscientiousness. It's mixed in with a whole bunch of other very important things, and it tends to capture what's predictively useful about those things, such that we can apply IQ scores to predict things like school performance, job performance, or where individuals will end up. So you can graph the average IQ in different academic disciplines of the professors in different academic disciplines. And in physics, you're in, 130s and 140s. And psychology professors are in, maybe the 120s. IQ is also related to health-related outcomes, in part through higher IQ predicting greater adherence to treatment recommendations and adoption of things like nutritional advice. And the argument can be made that there is an actual causal component here, that your intelligence or abstracting ability, your ability to solve problems, is independently related to these things, or causal or predictive of these things. That's not necessarily the most interesting thing about IQ. The more interesting things are the counterintuitive things, like the fact that the average IQ of chess grandmasters, i.e. people who have won chess tournaments that are composed entirely of people who have won chess tournaments, the average IQ of these people is 100. Practice rather than high IQ tends to be what is more predictive of ability to win at a game of chess. Not that IQ doesn't help. The other area which is counterintuitive is you tend to have an IQ that's similar to your siblings and your parents, but you tend to have an IQ that's even closer to your spouse than you do to your siblings. In other words, we tend to find people and pair with people who have very similar IQs to our own. IQ tests are arguably the coolest things that psychologists have made. They have been terribly misused, but they are very well made. They are well made because they were standardized. Your IQ score is how well you did compared to someone else of your age who is also from Canada. The test makers make a set of questions, some of which are probably going to get thrown out. They then ask a bunch of people in the same age group to answer the questions, and then you have an average number correct, and we have also an expectable spread. So an expectable maximum number correct, an expectable maximum number incorrect, and most people are going to hit roughly the average amount correct. So your IQ score is going to be reflective of how much you deviate from the mean for your age group. How many syllogisms did you answer correctly? How many block patterns were you able to reproduce? How many similarities questions were you able to answer at the correct level of abstraction? How many words were you able to define? I ask you all of these questions in the exact same manner that I asked the norm group, i.e. the group of Canadians that I got my averages and my spreads from. And I see where your score, your number correct, sits relative to the other Canadians in the sample, in the norm set. This gives me your deviation score, which translates to your IQ. So those with intellectual disability are those that score in the roughly first and second percentile on IQ and have adaptive challenges in their personal lives. More males than females qualify for intellectual disability diagnosis, in part due to chromosomal abnormalities. And under the current DSM-5 paradigm, we have 4 levels of intellectual disability, and these are determined not by your IQ score, but by your level of adaptive functioning, i.e. the extent to which you have trouble meeting the everyday demands of social and personal life. Interestingly, the more severe your intellectual disability, the less likely it is to be genetically heritable, i.e. the more severe forms are generally due to errors. But with that said, there's more than 200 known causes or problems/challenges that tend to lead to intellectual disability. On the topic of norms and standardization, we can ask the question, are Canadians smarter in terms of IQ than Americans. One thing that's interesting about the norm process is we will take common answers and we will add them to the norm set as expectable correct or incorrect answers. When I was administering IQ tests for Women's College and Sunnybrook Hospitals, we used the Canadian norm set, and one thing I noticed that was different between the Canadian and American norm set was some of the typical responses or responses that were frequent enough to make it into the norm set from Canadians versus Americans. Enough Canadian children, in response to the question on the Wechsler Intelligence Scales for Children test, enough Canadian children answered in response to the question, what is a cow, an ungulate, that made it into the norm set. And of course that's a 2-point answer, that's a full points answer, because that's correct. But that response didn't make it into the American norm set. In other words, when they were asking American kids, what is a cow, not enough of them responded an ungulate for that to make it into the expectable answers list. But here's our question. Are Canadians smarter than Americans in terms of IQ? On average, yes. What this means is, if I take an IQ score and apply American standards to it, the IQ score would be higher than if I applied Canadian standards to it. Americans would get more credit for the same answers than Canadians would get. The same responses are relatively more impressive in the US than they are in Canada. An example is the Wechsler Adult Intelligence Scales. If you apply Canadian standards to US scores, they score below average. If you apply US standards to Canadian scores, Canadians score above average. Put more specifically, the same answers could earn you an IQ of 114 by Canadian norms, but an IQ of 121 by US norms. Here's an example of somebody who ran the study with Ontario post-secondary students. Circled are the full-scale IQ scores. If you take the exact same answers to the exact same questions and you apply American norms, American standards, these individuals score an average IQ of 98.4. And if you apply Canadian norms, they score 91.2. Roughly 7 IQ points difference between the two norm sets. So, relevant to diagnosis, if I want a diagnosis to be reliable and hence have a hope of also being valid, I need people who could potentially give that diagnosis to know what it means, to know what the word and all of the words in the diagnostic criteria mean. With IQ, we have strict administration norms, so the way I introduce the tasks is all scripted so that everybody gets the same IQ test instructions. And it's the same idea with the International Classification of Diseases and the Diagnostic and Statistical Manual. We try to make things clear so that anyone attempting to come to a diagnosis is checking off the criteria correctly. We could come up with 2 quick examples here of a lack of standardization or standardization gone wrong. One of the items on the Wechsler Intelligence Scales for children and for adults is digit span. So I might say some digits to you and have you repeat them back to me, just like I said them. So 1, 3, 5, 4. Now you repeat them back to me. 1, 3, 5, 4. Now I put a pause, roughly the length of the number itself, 1, 1, 2, 2, between each number, so that you can't just bunch them together like one sound, like kids do with LMNOP rather than LMNOP. This is part of the standardization process. We asked all of the individuals who contributed to the norm set to recite the numbers back to us at that pace. So anybody that I'm administering the test to at a faster pace has an advantage because they can bunch the things together. There's less time for decay of the memory trace from working memory. And likewise, anybody for whom I insert longer gaps between the numbers and letters, 1, 3, would be at a disadvantage. So the norms, your deviation IQ score for each item and for the test overall, only makes sense if you've administered the test in the same way that it was administered to the individuals who contributed to the norm set that made up the scores that the individual is being compared to. An example pertinent to diagnosis might be a clinician who has a funny idea of what worry is. We'll probably all admit that there's some fuzz regarding what worry would be, and this is where clinical judgment comes into the picture when we're checking off our diagnostic boxes. But most of us would probably agree that simply having a savings account or having a life insurance policy does not constitute worry. One of the reasons why things like generalized anxiety disorder in the DSM-5 has poor inter-rater reliability is these negative affect terms related to the diagnosis of generalized anxiety disorder and major depression are a bit difficult to be standardized on. It's difficult for everyone to come to the same conclusion regarding all of the words in the criteria lists. Put in a bit more of a jargon-laden way, one clinician's threshold for clinical significance of a sign or symptom might be relatively high, leading them to not identify as many things as worry, or it may be relatively low, leading them to include more things in the category of worry than average. So let's see how far we've come in terms of specification and standardization. First of all, we note a difference between simply observing abnormality and classifying what type of abnormality that is. The former is called assessment. I'm assessing whether you have some sort of adaptive challenge or not. And the second is classification, i.e. appending or putting the right label onto the abnormality that we see, or that the individual is experiencing, or that is characteristic of the individual's way of being or perceiving the world. Back in 1840, we did not distinguish between assessment and classification, at least not at the level of the census. Here's how the Americans were doing it. They wanted to count the number of individuals suffering from mental illness in the country, so they had a box on the census so that you could specify if a member of your household was insane and idiotic. Now today, most students read that and they say, wait, you had to be both? What is this? What does this mean? And really, it just means abnormal. Obviously abnormal in a way that would have been recognized by doctors and asylum directors in 1840, but there's no effort to specify which type of mental illness one has. The strange phrasing here, insane and idiotic, seems to carry with it the belief that if you are one, then you are both. But of course, that's just the census. We have been making efforts to specify which type of abnormal individuals are since well before then. Here's a quote from Immanuel Kant, who of course was writing well before 1840. Physicians think they do a lot for a patient when they give his disease a name, i.e. when they go beyond noting simple abnormality and move to the step of classification. In the Raskin reading for this lecture, he relays how much emphasis has been placed on reliability. It is what, since the DSM-3, since 1980, the DSM task forces have been focused on, and it's what the World Health Organization's International Classification of Diseases Manual has been adopting or copying from the DSM approach. This shift from trying to adequately capture in complete paragraphs a description of a disorder versus making a checklist so that you can find all of the hallmark or key features of a disorder was in response to two things. One being David Rosenhan's study on being sane in insane places, published in 1973. But before that, we had research by Aaron Beck and individuals in Europe who were noting inter-rater reliability estimates of around 54% for the big major disorders, like schizophrenia and bipolar disorder, or what we called then manic depressive disorder. This means that roughly, if you had a diagnosis of schizophrenia and you went for a second opinion, you would get the same opinion roughly half of the time from that second assessor. And this is for schizophrenia. So the DSM-3 in 1980 said goodbye to the DSM-2 psychodynamic Freudian-influenced approach. So here's an example from the 1968 DSM-2 edition. This is how you would diagnose someone with anxiety neurosis. You have this paragraph in mind. This neurosis is characterized by anxious overconcern extending to panic and frequently associated with somatic symptoms. Unlike phobic neurosis, anxiety may occur under any circumstances and is not restricted to specific situations or objects. This disorder must be distinguished from normal apprehension or fear, which occurs in realistically dangerous situations. We'll return back to this distinction between anxiety and fear later. Now I just want you to notice that this is all you get. This is the paragraph that tells you how to diagnose anxiety neurosis, which we would now call generalized anxiety disorder, although there might be some other anxiety disorders that could fit in this description because it's so general. So here it is in its more inter-rater reliability friendly form from 1980. Diagnostic criteria for generalized anxiety disorder. Generalized persistent anxiety is manifested by symptoms from 3 of the following 4 categories: motor tension, autonomic hyperactivity, apprehensive expectation, vigilance and scanning. The anxious mood has been continuous for at least 1 month. It's not due to another mental disorder, such as depressive disorder or schizophrenia. And the individual you're diagnosing is at least 18 years of age. There's still a lot of fuzzy concepts here, but now at least we have rules that different individuals can follow. Everybody knows to look for these concepts, these signs and symptoms, and how many and which ones need to be present in order to give someone a diagnosis. Of course, it is still the case that today we have poor inter-rater reliability for generalized anxiety disorder. But this is how, for the last 40-odd years, we've been working on addressing that challenge. I chose the Raskin reading for this lecture because it actually presents you with the alternative models to the DSM and the ICD. Most textbooks will give you the DSM and then be like, oh, and there's another option out there, ICD. But astute students tend to notice that if they reference each other's codes, i.e. if everything that's in book A is in book B, then they can't be that different, can they? I lumped the DSM and the ICD together as kind of one concept, one tool. Even though the DSM does a better job of itemizing things, Raskin gives you an introduction to the Psychodynamic Diagnostic Manual, which I will be using in the Personality Disorders lecture, because that's the thinking tool that actually helps me get my head around personality disorders. The DSM and ICD do pretty much nothing for my understanding of those. And the Raskin reading introduces you to research domain criteria. So the U.S. National Institute of Mental Health was so disappointed that the DSM-5 didn't make most of the changes that they said they would, that it just came out and decided, we're tired of using the DSM map. The way the DSM splits up the world in terms of diagnoses has not been found to be as reliable and valid as we want at the National Institute for Mental Health. So we're going to split things up into research domains. So we're going to classify things according to negative valence systems, positive valence systems, your arousal or regulatory systems, your interpersonal or social processes, and your cognitive language memory types of systems. We're going to use that as kind of our first pass filter. So if a client is presenting with a problem that is related to negative emotion, like anxiety or depression, we're going to look in that domain for relevant information and ways to assess them. In general, the DSM kind of has an implied premise that depression is as different from anxiety as it is from schizophrenia. The DSM acknowledges comorbidity or overlap, i.e. those with depression are more likely to have anxiety. But the extent to which this is true, and it's something like half of individuals with major anxiety disorders can be expected to at least transiently develop a depressive disorder. This extent of overlap is not well recognized or well explained by the way the DSM cuts up the world and puts borders around the disorders and concepts. The research domain criteria approach is attempting to build a better map with a better representation of reality, starting from facts and observations like this great degree of overlap or similarity or conceptual relation or, at bottom, probably biological similarity of anxiety and depression, or anything else that we can expect to get bunched together in our observed clustering samples of reality. So when you stack this institutional rejection of the DSM with some of the other DSM criticisms, like its lack of inter-rater reliability despite its nearly exclusive focus on obtaining inter-rater reliability for many disorders, many students come to ask, why are we using the DSM at all? And the answer lies in who is using the DSM and why. So you have researchers that need common categories and what people nearly ubiquitously refer to as a common language, a term that I think is a bit presumptuous, because if different people are calling things by different words, or more concisely, if people are using the same word to refer to different things, then that's as analogous to having two different languages than it is to having one common language. If I think two refers to TWO and you think two refers to TOO, that's not a common language. That's a homophone across two different languages. But my particular distaste for the common language phrasing appears to be idiosyncratic to me. One of the groups of people who use the DSM are researchers who need to be able to categorize individuals, cases, research grant funding allocation into different domains. The National Institute for Mental Health in the US would be one example of a research organization that has opted out of the DSM, replacing it with their research domain criteria, but most other organizations need to use DSM language in order to get funding and recognition and understanding for and about their work. Next, clinicians need categories, like disorder categories, in order to develop an expertise to begin with. Having a name for something, having a category for something, is helpful even if it is a poor or a fuzzy category. Our brain, our expert schemas need organization. There's also a big system that needs to be somewhat understandable. If, for some reason, we stopped distinguishing between depression and anxiety, then how would we know, for example, how many antidepressant pills versus anxiolytic pills to make for a given year? One area where the DSM gets criticized quite a bit is the threshold for diagnosis of given disorders. Many of the individuals who end up on the DSM task force that makes decisions about disorders and criteria to diagnose them, also by virtue of being at the top of their field, are consultants for things like pharmaceutical companies. So there's often a conflict of interest there, because if you influence the committee to lower the threshold for diagnosis, then a company from which you get a paycheck would receive a boost in sales. And this need not be an organized or intentional or clandestine conspiracy. If I genuinely believe that the population would be better off if everyone was taking Soma, as one might expect from someone whose life work is in the field of Soma medication, then I would likely be okay with lowering the threshold for entry into a category of individuals for whom prescription of Soma is covered by insurance or federal health care. So there's a big system of many individuals that would be very much impacted and changed if we went off of the DSM standard, started using other concepts, or changed how we look at mental illness generally. The courts also use DSM categories, or at least experts and professionals who refer to these categories, to determine things like whether an individual was responsible for an act, whether they continue to remain dangerous, and many seemingly arbitrary decisions made by the DSM in the past have turned out to be very impactful. The DSM-4 introduced the idea of axes, so you have the major Axis 1 that contains things like your manic depressive and psychotic disorders, but they had on Axis 2 personality disorders and intellectual disability. Now, this was meant in part to be an acknowledgement that any disorders of personality or intellectual functioning could be independent of other major psychological disorders you may have, but it was interpreted by courts and insurance companies as a downplaying of personality disorders, as if they were not real psychiatric disorders. And you may agree with this, although I doubt you would agree in the case of borderline personality disorder, which can be quite extreme. But this distinction may be one of the reasons why nearly no one would say that they're not criminally responsible for reasons of a mental disorder on account of a personality disorder, whereas individuals will make that claim for adjustment disorders, psychoses, bipolar, and PTSD, which of course brings us to the public. I don't know about you, but I would get a little bit nervous if I heard that the federal or provincial government were suddenly changing how they viewed mental disorders. This could mean that more individuals will be found not criminally responsible for dangerous behavior and hence be set free or less monitored, but it could also go in the other direction, such that the little assurance that I have that if I suddenly split from reality and experience schizophrenia, the government will put me in an institution of healing rather than a prison cell. That reassurance might go away if they redefine psychosis or how they determine whether somebody meets criteria for a psychotic break from reality. We, as members of the public, count on our organizations to have some coherent and non-fluctuating interpretation of mental illness to make sure we're not in some strange Kafka-esque version of reality where nobody knows what to expect or nobody knows what anything means. We are currently in the DSM/ICD paradigm or version of reality, whereby these concepts are what we understand mental illness to be, and the concepts or categories that get special treatment and attention, and hopefully are also the categories that we can take a meaningful and useful and just action in reference to. Now with diagnosis, we're dealing with kind or classification. We've established that differences exist through our SNIDS model, SNIDS, suffering, norms, infrequency, dysfunction, and surprise. Now let's work on classification of that abnormality. A diagnosis exists to specify a problem and thereby find a treatment method. It also allows us to figure out in the first place that there is a treatment method for a given type of problem because we followed individuals with a given type of problem and we've tried things with this population. There are some disorders that have been labeled culture-bound. The assertion there being that they're only found in certain places where people hold certain beliefs. A popular example of this is Koro, because it's a nice and specific type of disorder. There's a very specific concern that your genitals are shrinking or receding into your abdomen, and this affects both men and women. This would be pretty easy to classify, pretty easy to diagnose, because you have such a specific concern. I doubt that any specific problem is going to actually be truly culturally bound. For example, Koro has been discovered elsewhere, but this disorder should be pretty easy to identify wherever you happen to encounter it. Another disorder thought to be culture bound is amok. So if we say someone is running amok, it means they're making a mess of things. The word came from a description of disordered behavior we noted in a few different places. Essentially, the individual appears to go into a depression and then proceeds to engage in indiscriminate violence, for example with a machete. Now, this is listed as a culture-bound syndrome, but it kind of boggles my mind that North America isn't on here as one of the cultures in which we see amok. Surely at least some of our school shooters were brooding before their shooting event. The flip side of a culture-bound disorder is what's called a universal disorder. We see schizophrenia wherever we see groups of humans. We see alcoholism wherever we see groups of humans with alcohol. We see psychopathy wherever we see groups of individuals who have to deal with individuals who don't follow the rules of the group. And we see intellectual disability everywhere we look as well. These disorders do not appear to be limited by or induced by any particular cultural practices, but rather natural parts of human diversity, regardless of where or in what situation we find these humans. Also, in one of the appendices in the DSM-5 is a cultural formulation interview example. The idea behind cultural formulation is you should describe the challenges that the client has in their own terms and in the language of their own culture, family, environment, etc. Key to doing this is finding out how the client describes their problem. So the cultural formulation interview gives some examples of good questions to assess what type of help the client wants and what they think is actually the challenge that they're facing. A good incisive question from this cultural formulation interview is, are there other kinds of help that your family, friends, or other people have suggested would be helpful for you now? This question might help us get at whether we're dealing with an individual who, from earlier in the lecture, might think that a psychological approach needs to be supplemented with a spiritual one, or might be struggling with family members who believe that, or might even just be using you as a stepping stone to getting an exorcism, because the Archdiocese in Toronto will not do an exorcism unless you've had a psychological consult first. Now let's walk through a diagnosis, or at least let's walk through the DSM that we would use in order to diagnose. Do you have a substance use disorder? Are you popping too many pills or smoking too many marijuana cigarettes? Let's take a look. In order to get diagnosed with a substance disorder, you need a maladaptive pattern of substance use leading to clinically significant impairment or distress as manifested by 2 or more of the following occurring within a 12-month period. So you only need 2 occurring within the last year. First, recurrent substance use resulting in a failure to fulfill major role obligations at work, school, or home. For example, repeated absences, expulsion, or child neglect. 2. Recurrent substance use in situations in which it is physically hazardous. Do you drive drunk, for example? 3. Do you have a strong desire or cravings to use the substance? Now 3 is circled here because this criterion used to be different in the DSM-4. In the DSM-4 we had, did you ever get in trouble with the law regarding your substance use? Now as we know, some groups are a little more targeted by law enforcement than others. So the DSM wanted to remove that criterion, and it just so happened that we have a ton of new great research on craving and the neuroadaptations and sensitizations in the prefrontal cortex that happens when you get addicted to something. So we replaced trouble with the law with strong desire or cravings for the DSM-5. Criterion 4, continued substance use despite having persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of the substance. For example, do you fight with your spouse over having used the substance? Do you have chemical tolerance defined by either the need for increased amounts of the substance to achieve the same effect or a diminished effect when you continue to use in the same amount? Your body's getting used to it. It's upregulating the response that tries to keep you in homeostasis. i.e. you're getting better at fighting the exogenous substance that you're sticking into your system, and you therefore need more of it if you want to make yourself as high as it was making you before. Withdrawal, as manifested by either the characteristic withdrawal syndrome of the substance, which is going to be different for every substance, or taking more of the substance in order to avoid this characteristic withdrawal syndrome. So what's happened with withdrawal is your body has downregulated its own ability to independently create the natural version of the substance that you're sticking into yourself from the outside. 7. The substance is often taken in larger amounts or over a longer period than was intended. 8. There's a persistent desire or unsuccessful efforts to cut down or control substance use. This criterion is one of the reasons why roughly 90% of the people who smoke cigarettes are addicted to cigarettes. Most of them have tried to quit and failed. 9. A great deal of time is spent in activities necessary to obtain the substance, use the substance, or recover from its effects. Here you can see how an illegal substance might be more likely to have you tick off this box. It's pretty easy to get cigarettes, it's pretty easy to get alcohol, maybe a little more difficult to get an illegal substance, so you may be more likely, if your substance happens to be illegal, to be able to check off item 9. 2 more. 10. Important social, occupational, or recreational activities are given up or reduced because of substance use. And 11. The substance use is continued despite knowledge of having a persistent or recurrent physical or psychological problem that is likely to have been caused or exacerbated by the substance. So an ulcer made worse by alcohol consumption, or maybe you have anxiety or psychotic symptoms that are made worse by the substance that you're taking. Now, way back in 1994 in the DSM-4, the substance use disorder category was actually divided into substance abuse versus substance dependence. We didn't really have a good reason for the bifurcation. Now we have 3 versions of substance use disorder. We have mild, moderate, and severe. So if you can tick 6 or more of those diagnostic criteria from the previous slides, then your substance use disorder is severe. So in DSM-5, we have the following organization here. You have substance-related and addictive disorders. So you can have blank use disorder, cannabis use disorder, or alcohol use disorder, whatever substance it is. That's what gets filled in there. And then you have non-substance-related disorders, such as gambling disorder. Which version of the DSM distinguishes between substance abuse and substance dependence? Version number 4. You'll see the terms substance abuse used a lot in literature. We have tons and tons of great research on the DSM-4 conceptualization of substance-related disorders. That research does not get thrown away just because of a few changes in diagnostic criteria for version 5. As a final exercise, I invite you to go through the case of James, presented here, 4 diagnostic options. The first being no diagnosis, the others being intermittent explosive disorder, conduct disorder, or oppositional defiant disorder. To conclude this lecture, diagnosis is something that's facilitated by our attention to detail, our noting down faithfully what is in front of us, so that our memory does not play tricks on us, and so that we pay attention to what is not there. Our adherence to standards of proper administration, proper norms for use of the concepts, proper reference to population norms if we're assessing whether something is abnormal, dysfunctional, maladaptive, clinically significant, and adhering to the rules of common understanding that our discipline and society expects us to. Next lecture, we'll talk about some pitfalls and ways to get better or good knowledge about disorders. Stay tuned.